Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. In the early days of the COVID-19 pandemic, when there were no vaccines or treatments, convalescent plasma, antibody-containing blood from people who recovered from COVID-19, saved countless lives. Today, we bring you an episode from our friends at the podcast MMI Monthly, From Bench to Breakthrough. Guest host Thomas Locke talks about how nearly 5 years later, convalescent plasma has received FDA approval to be used as a potential treatment for immunocompromised patients. Let's listen.
Hello and welcome to MMI Monthly, a podcast sharing public health stories from bench to breakthrough. I'm Thomas Locke. Today we focus on the evolution of COVID-19 convalescent plasma, CCP, from its emergency use during the pandemic to a newly approved treatment protecting immunocompromised patients against COVID-19. Our podcast follows the news that OneBlood, a not-for-profit blood centre in Florida, has had its application to manufacture and distribute convalescent plasma for COVID-19 fully approved by the FDA. This is the first ever approval for convalescent plasma. To understand how we've got here and the significance of that approval, we need to go back to the early days of the pandemic, because it's here that the idea of using convalescent plasma for COVID-19 was born. Here's David Sullivan, MD, an infectious diseases physician and professor in the Molecular Microbiology and Immunology department, on the challenges of treating patients in 2020 at the start of the COVID pandemic.
For SARS-CoV-2, we had a high case fatality rate. We did not have any available drugs, and we know antibodies work. We use them for vaccines. They were a therapy before we had drugs that worked, although often drugs do work better than antibodies, but we don't have available drugs.
One population in particular faced an additional risk.
There's about 3% of the U.S. population, about 10 million people, that are unable to generate their own antibodies either through past infections or with the vaccinations, or they can't make enough antibodies to be protective. But they make up about 20% of all the hospitalizations, so they bear the brunt of the severe disease.
So you've got this perfect storm of an emergent virus, no available drugs or vaccines, and a vulnerable population of 10 million people who can't produce protective antibodies after vaccination or after COVID-19. Scientists questioned how best to protect them. Whilst vaccines are the gold standard, they take time to develop and might not be enough to provoke the immune system to produce sufficient antibodies. So they looked to an old therapy called serum therapy. Here's how it would work. Historically, you'd infect an animal with a disease, let it fight it off, and take their blood, remove the red blood cells and the white blood cells, and give the plasma, the liquid part of the blood containing these antibodies, to a person who hasn't been exposed to the disease who needs protection. Serum therapy was used in the influenza pandemic of 1919, for measles in 1934, and mumps in 1946, demonstrating the potential of transferring immunity through antibodies. Convalescent plasma uses the same principle, this time in humans. It's the transfusion of a natural repertoire of antibodies from a human patient who's already recovered from the disease to someone who needs protection, a way of transferring immunity. One person can protect up to 3 people with a single donation and up to 10 people in multiple sittings. And it's this idea which led the chair of MMI, Arturo Casadevall, to write an op-ed in the Wall Street Journal highlighting the benefits of antibodies from recovered patients. The problem was that while the FDA had granted an emergency use allowance for convalescent plasma in August 2020, it was only for those who had already been hospitalized. To be eligible, you had to be sick enough.
My thinking with the outpatient trial is that we can't wait till our friends and family are sick enough to get to the hospital to give them an intervention, but we have to target those at high risk for an intervention when they have mild disease. let's go ahead and do a randomized clinical trial, which gives you the highest level of proof. We also designed our trial thinking about the end product. We wanted to include pregnant women. A lot of trials just focused on people older than age 50 or older than age 65, but we went ahead and included people of all ages from 18 up. I would like to thank our sponsors from the Bloomberg Philanthropy and the state of Maryland who gave us the seed money. We were buoyed by Operation Warp Speed and the Department of Defense funding a lot of the trials. Hopkins is a great place to work. The blood bankers were here, and there was a strong infectious disease bench. So the infrastructure is here. We got a good group of people together and were able to lead the outpatient trial and make it multi-site throughout the nation.
In that randomized control trial, in which neither the patient nor the investigators knew which treatment groups the patients were in, there was a 54% reduction in hospitalizations in largely seronegative, immunocompetent patients.
We had 17 hospitalizations in the convalescent plasma group and 37 in the non-convalescent plasma group.
That trial formed part of the FDA's decision to extend the emergency use allowance to include outpatients. And it's since been found to not only provide an immediate immune boost, but also to be effective in 4 stages of COVID-19.
It's efficacious in preventing mild COVID-19 from progressing to severe as an outpatient. We know it prevents deaths in those hospitalized. If someone is newly intubated, newly on mechanical ventilation, there was a Belgium study that came out about a year ago that showed that it prevented deaths within the first 48 hours of intubation. And then there was a recent randomized clinical trial from Germany that showed that it also prevents disease progression in those that are immunosuppressed. We don't have the evidence that convalescent plasma prevents infection. There's lots of evidence that it is good for treatment and in those 4 phases of the disease: the outpatient phase, the hospitalization phase, those that are newly intubated, also those that are immunosuppressed.
It's this culmination of research that led the FDA to grant a blood bank in Florida a BLA license, which allows it to manufacture and distribute convalescent plasma outside of the emergency use allowance, and to do so at a higher concentration, around 20% more potent than in emergency use. This is important as it reinforces the role of convalescent plasma for those who are immunocompromised, but also that the benefits outweigh the risks even outside of the height of the pandemic. I asked Professor Sullivan how the treatment will be used in the field.
I want to address that there's been 2 things going on. Our antibodies as a population have been rising 20-fold with vaccinations and having repeated episodes of SARS-CoV-2 or COVID-19. Just our total number and our neutralizing capability of our antibodies have risen over that time period. And we're working with the FDA to make certain that what we're using for transfusions are in the upper 20-30% of all people. We know that early in the pandemic, even if you had a documented infection, there were 10 or 20% of the people that made no to little antibodies and would not be able to be used as therapy. It's really just those top 10 or 20% of the antibody producers that have enough antibodies that when you dilute it, transfuse it into someone, you get that dilution. Another point that I want to make on the population is the FDA did not put any age restrictions on it, so it's going to be very useful for kids that are also immunosuppressed. The FDA talked about, the indications for use, word for word, were treatment of COVID-19 in patients with immunocompromised, immunosuppressive disease process or receiving immunosuppressive treatments at risk of severe disease progression in either the inpatient or the outpatient setting. Not said is, it didn't say just for adults. So this says that kids are included in this. So it's inpatient and outpatient, those that are either have an immunosuppressive disease or receiving an immunosuppressive treatment. Those are the ones that are eligible and will benefit from the most. So it's those that really lack sufficient antibodies at the present time.
Looking forward, I asked whether this is something of a blueprint for future pandemics.
I would say that Convalescent plasma is not for every disease. You sort of need something that's rapidly spreading, has a high case fatality rate that you want to prevent, and that there's no alternative drugs. And that's sort of the setting or the blueprint to deploy convalescent plasma. No one wants to wait till they're sick enough to get to the hospital than to have available intervention. So then that brings us back to where we are now. We still have this 10 million people that lack antibodies, and they do suffer a higher hospitalization rate and a higher case fatality rate. And so for them, those principles are still operative.
In the right circumstances, convalescent plasma can revolutionize treatment for immunocompromised patients. Whilst vaccines remain the gold standard, they take time to develop. And for those who are immunocompromised, they might not be enough to produce antibodies against the disease. The work of Professor Sullivan and a host of collaborators from the Johns Hopkins School of Medicine to the Mayo Clinic has shown that convalescent plasma is safe and effective. My thanks to Professor David Sullivan from the Johns Hopkins Bloomberg School of Public Health. This has been MMI Monthly, a podcast from the Department of Molecular Microbiology and Immunology at the Johns Hopkins Bloomberg School of Public Health. I'm Thomas Locke.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharpstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.